Thank you for joining us this morning for another webinar in our Preventive Services series. My name is Karen Curtis, and I am a Provider Outreach and Education Specialist at WPS Government Health Administrators. I am joined today by my friend and coworker, Aline Sigler. We also have a member of our clinician team that's on with us. Aline will be helping me out today by adding information into the chat, and she's also going to monitor for any questions that you may send in. Preventative services has been added to surveys as a topic that you would like to see for future education. And this led me to create a series where I've separated out the different services into individual webinars. And that way I can cover the coverage and the billing requirements in more detail. There's another coworker of mine, Jennifer, who is she's part of the clinician team, and she has also been doing a webinar series on preventive services, but she's been covering more of the clinical aspect, where she's kind of going over the NCD and documentation requirements and things like that. So we have separated it out so that we can cover that information in more detail for you. Today, we will be talking about medical nutrition therapy. This next slide is our disclaimer. We do our best to provide the most current, accurate information, but as we all know, Medicare rules can change often. So the information that I'm presenting is accurate as of today, but the CMS website should be checked often for updates. CMS does prohibit recording of this webinar for profit-making purposes. So we ask that you do not record or take screenshots of the presentation. This event is being recorded and will be posted to the WPS GHA website on the Encore Presentations webpage, as well as to our YouTube channel. As with most of my webinars, I'm going to give you a little background information on how it came about that Medicare would cover preventive services. We'll discuss coverage criteria for medical nutrition therapy, how to bill Medicare for those services, and finally, we'll talk about eligibility so that you know if patients are eligible to receive certain services, and it will also allow you to avoid frequency rejections. I have provided a list of acronyms just in case I may use one in this presentation that you're not familiar with. I'm going to start out this morning with a little background information regarding preventive services and how it's determined if Medicare will cover the service. Receiving preventive services has been shown to improve health. It increases workplace productivity, and it reduces the cost of health care. Yet it has been found that Americans are using preventive services at about half of the recommended rate. The Affordable Care Act was signed into law on March 23rd of 2010, and it required health plans to provide specific items and services, recommended immunizations, and recommended preventive care and screenings without cost sharing. This act also made it unlawful for any healthcare provider who receives federal funding to refuse to treat an individual or otherwise discriminate based on race, color, national origin, sex, age, or disability. Covered services are reviewed, and those that have strong scientific evidence of being beneficial must be covered at no cost to the beneficiary. The U.S. Preventive Services Task Force, or Task Force, is a volunteer group that was created in 1984. The 16 members consist of national experts who come from a variety of fields, including family medicine, behavioral health, and nursing, among others. These individuals make evidence-based recommendations regarding preventive services. They focus exclusively on services offered in a primary care setting or services that are referable by a primary care clinician and that apply to patients who have no obvious signs or symptoms of a specific disease. Each service is reviewed to determine if there is evidence that the service is effective and the balance of benefit versus harm. These services are then assigned a letter grade, and those who receive a letter grade of an A or a B are offered without cost sharing. Now, before we go into the billing details, I want to talk a little bit about coverage. So what criteria must be met in order to bill Medicare? Beneficiaries should be entitled to Medicare Part B. Patients must have a referral from a physician for medical nutrition therapy, and they should be diagnosed with diabetes, renal disease, or have had a kidney transplant within the last 36 months. Services must be performed by a registered dietitian or a nutrition professional. The registered dietitian or the nutritional professional should be licensed or certified in the state where services are performed. I will go into a little bit more detail and I'll show you where you can find the regulations on the qualifications for the dietitian or the nutritionist towards the end of the presentation. Now, if the dietitian or the nutritionist would like to bill Medicare themselves, they would need to enroll as a Medicare provider. They would need to obtain an NPI and also accept assignment. Services that are included in medical nutrition therapy include an initial nutrition and lifestyle assessment, individual and or group therapy, help managing lifestyle factors, and follow-up progress visits. So now we can move on to what should be included on your claims when you're submitting those to Medicare. We'll start out with talking about the payable codes. So 97802 is for the initial assessment and intervention. So because it's for the initial assessment and intervention, this code can only be used once, and that would be for a new patient. 97803 is reassessment or intervention, and this code is used for any assessments or interventions that occur after that initial visit. It would also be used if there is a change in the patient's medical condition that would affect their nutritional status. The 97804 refers to group therapy, and it should involve 2 or more individuals. Now, this code can be used for initial and subsequent group visits. It can also be used if there is a change in the patient's condition that affects their nutritional status and the patient is attending group therapy. Now, these 3 codes can be paid if they're submitted by a registered dietitian or a nutrition professional, or it can be included in the hospital claim if that hospital has received reassignment benefits. It does list in the CMS manual that these services cannot be paid incident to physician services. On this slide, it also has a couple of G codes that can be used to bill. G0270 is for individual sessions for reassessment or subsequent interventions when a second referral is needed in the same year for a change in diagnosis, medical condition, or treatment regimen. G0271 is for group sessions for reassessment or subsequent interventions when a second referral is needed in the same year for a change in diagnosis, medical condition, or treatment regimen. Now, these G codes should be used when it's anticipated that additional hours are going to need to be provided past the typical frequency coverage. And this would occur when the physician determines that there needs to be a change in the patient's diet due to a change in their diagnosis or their medical condition. If you are submitting a claim using a CMS 1500 or an 837P, you'll want to include specialty code for dietitians or nutritionists, and that is the specialty code 71. For those who are billing using a UB04 or an 837I, I've listed the applicable type of bills. Now, medical nutrition therapy can be billed when performed in an outpatient hospital setting. If the nutritionist or the dietitian has reassigned their benefits, then the hospital can submit a claim using the Fiscal Intermediary Standard System known as FIS. If the hospital does not get the reassignment, then the claim would need to be submitted using the multi-carrier system or MCS. This can be done by the dietitian or nutritionist under their own provider number, or it can be done by the hospital. I'm going to take a moment and we're going to talk about federally qualified health centers and rural health clinics. If you are an FQHC who receives payment under the all-inclusive rate, then additional payment can be made for the medical nutrition therapy services. To qualify as a separate visit, the services must be a one-on-one face-to-face encounter, and the charges should be billed on a 77X type of bill. It should include HCPCS code 97802, 97803, or G0270, along with the appropriate 52X revenue code. For FQHCs who are paid under PPS, then the medical nutrition therapy does not qualify for a separate payment. Services should be submitted on a type of bill 77X under HCPCS code G0466 or G0467, and that's going to be billed along with the appropriate 52X revenue code. If you happen to be a rural health clinic, there is not a separate payment for the medical nutrition therapy services. Medicare allows for 3 years of training during the beneficiary's initial calendar year. 2 hours are allowed for subsequent years, but it will need a physician's referral. If the beneficiary receives a second referral within a calendar year due to a change in diagnosis, medical condition, or treatment, then that's when you're going to want to use those G codes for billing that we covered earlier, because your services could go past this limit that CMS has set. Now, I do want to go over some eligibility today, and this is going to let you know when the beneficiary is able to receive certain services and to help avoid frequency rejections. There are different options for checking eligibility. There's the interactive voice response line, which is also referred to as the IVR. The GHA portal is a secured section of the WPS-GHA website. And if you're a provider who bills using the FIS system, then direct data entry is an option. Finally, the HIPAA eligibility transaction system can also be used for electronic responses. Our first option is the interactive voice response, or IVR. We have been told by our customer service management that this is not really a favorite of providers. They did want us to stress that you can just speak to the voice response unit. It should be able to pick up what you're saying and provide the answers that you are looking for. We have been told recently that the customer service management team has been working with CMS to try to make some improvements to the IVR. I know one thing in particular was we've had providers tell us when they're trying to go to a different department, they'll press 0 and they get taken to the survey. So there are some changes being made to that, which will hopefully improve how it works for all of you. Our portal will also provide information on preventive services eligibility. The eligibility check is under the My Transactions, and then when you enter the patient's information, then you'll select the Preventive Services tab, and that should provide you with eligibility dates for all of the preventive services. There is a list in the portal manual, the user manual, that will give you what information will be provided. And while we're talking about the portal, I'd also want to let you know that some work is being done on the secured side. We are enhancing the programming, the servers, and it's going to make the look a little different, hopefully make it more stable. We will continue to evaluate the functionality after the changes have been made. And although we have not been given an exact date of when everything's going to be completed, we are being told that it should be by the end of summer of this year. For providers who bill using the Fiscal Intermediary Standard System, also known as FIS, direct data entry is an option. There is a form that can be found on the WPS-GHA website, and that does need to be completed in order to request access. But once you get that, you can enter a beneficiary's information, and if you choose the beneficiary common working file, there's actually 16 pages of eligibility information. So there is a lot of information available with the direct data entry. The last option that I want to talk about today is HETS. So this would require you to register for a trading partner account, and then you would be able to electronically submit a 270 inquiry, and you would then receive a 271 response. I put a couple examples on here of what that would look like. The first one is if the professional and technical date are the same. And the second example would be if the professional and the technical date have different dates for when they're next eligible. They'll just break that into two separate lines. I have provided you with some resources in case you would like some additional information. There are a couple that I would like to go over and show you guys. Let me get out to the internet real quick. Lean, can you confirm that you can see the Medicare Preventive Services tool?
Yes, you're in the right place.
Okay, great, thank you. This is a tool that I find very helpful regardless of what type of preventive service that you are looking for. Since we are talking about medical nutrition therapy today, we'll click on that one. It does have the telehealth eligibility symbol that tells you that is an option. It lists the HCPC and CPT codes that can be billed. If there are specific ICD-10 codes, those would be listed here. It gives you the criteria for what Medicare will cover. Down here, it gives a frequency. And it also has if the patient would owe any money, co-payments or co-insurance, or if deductible would be applied. And then not for all services, but some of the services also has these other notes. So for instance, this one talks about how diabetes self-management cannot be billed on the same data service as medical nutrition therapy. There has been some updates where it says a registered dietitian or nutrition professional must personally perform the MNT services they bill for. Enrolled registered dietitians and nutritional professionals may bill for on or on behalf of a diabetes self-management entity. So there is some additional information there. I also, because I got some questions about the criteria of who can perform these services, I did provide you a link to the Code of Federal Regulations and specifically to the medical nutrition therapy. If we scroll down here to the bottom, it does list the provider qualifications. So it talks about holding a bachelor degree, completing 900 hours. There are some exceptions. If they're licensed or certified as of December 21st of 2000, then they don't have to meet the A and B requirements. So I do think that that would be something that would be helpful. This is just the manuals. This was the one for the federally qualified health centers and rural health clinics. I did provide you with links for both of those. We'll go back to the presentation. I also gave you like the U.S. Preventive Services Task Force. They do have a list of all the services that are considered A and B and would be offered without cost sharing. So I didn't know if that was something that maybe might interest some of you. Now, before I turn it over to Aline to see if any questions have come through the chat, there are some that I would like to address, the pre-submitted questions that I received. The first question I received was if medical nutrition therapy is billable as incident 2 under the physician. And according to the Claim Processing Manual, Chapter 4, these services are not billed, cannot be billed as incident 2. That manual was one of the links I provided on the resource slide, so you can go back and read specifically about that information. The next question I received was, can medical nutrition therapy be billed when a patient is admitted in the hospital, regardless if the status of the patient is inpatient or observation? This was another one that I did find in the CMS manual. They stated that payment is only made for beneficiaries who are not inpatients of a hospital or a skilled nursing facility. So that the answer to that would be no, they could not be an inpatient. Another question asked is there a difference in the requirements of the services are provided in an RHC or a hospital outpatient setting? That you can find in the Rural Health Clinic manual. That's where they said that it was not paid separately. If the dietitian or nutritionist reassigns their benefits to the hospital, then the hospital could submit a claim to the Part A on a UB04 or an 837I. Otherwise, the hospital would need to submit a Part B claim using the CMS 1500 or the 837P. Now, that is all I had for the pre-submitted questions, so I'll ask Aline, have we gotten anything through the chat?
Hi, Karen. Thanks for that great information. And I have scrolled through the chat, and I do not have any questions for you right now.
Okay. Well, I will continue on. Now, before I go on to closing, I'm just going to check with Aline one more time and see has any questions come in?
We did get a question from Natalie, and it says, can the MNT be billed by an RD working within an outpatient department when the supervising physician is within a separate physician-based clinic?
I would say yes to that, because the services, as long as the registered dietitian or the nutrition professional, if they've gone through the process of getting their own provider number, then they would be able to bill for their services. So hopefully that answers the question. This brings us to the end of today's presentation. Keep an eye out on our live events, upcoming events. Tomorrow, we're going to be holding a couple webinars on prior authorization. And then on Thursday, one of our team members will be holding a webinar on the opioid treatment program. So those are a couple things to look out for. On behalf of Provider Education, Outreach and Education, thank you for joining us today. We look forward to your survey comments, and we hope that you will join us for future events. You may now disconnect.